You're working a cardiac arrest and your patient achieves a return of spontaneous circulation. You're observing the 10-minute cool down and you're acquiring vital signs. How predictive are those vital signs of your patient rearresting and ultimately not surviving? And are there parameters around those vital signs that make it more likely or less likely that your patient will rearrest and not survive? I'm going to put 5 groups, 5 clusters of vital signs on the screen, and I want you to order them from the least likely to rearrest and not survive to the most likely to rearrest and not survive. And you can pause the video to do that. This recent paper is a cohort study from ESO looking at cardiac arrest patients who achieved ROSC between the years 2018 and 2021. And they grouped these patients into 5 clusters of specific types of vital signs. Cluster 1 was hypertensive. Cluster 2 was normotensive. Cluster 3 was hypotensive and tachycardic. Cluster 4 was hypoxemic with an increasing systolic blood pressure, and cluster 5 was hypoxemic with a decreasing systolic blood pressure. The results were actually pretty predictable. Cluster 1 was the least likely to rearrest and survive, and with that hypertension you can see that there was a robust response from that heart. And then that increased in the likelihood to rearrest and not survive as you progress from cluster 2, 3, 4 to 5. The take-home point for this is that if your patient isn't fighting back hard or at least not compensating well, they have a significantly increased likelihood of rearrest and not surviving, and you need to be aggressive and manage them appropriately. Link to the paper in my bio.